Hello and welcome everyone. Thank you for joining this live conversation hosted by Aspen Global Innovators Group, Aspen Health for All. This series of conversations that the Aspen Global Innovators are putting together are aimed at addressing the disparities that have been amplified and highlighted by the COVID-19 pandemic. It is my pleasure to introduce and welcome Dr. Paul Farmer, the founder and Chief Strategist of Partners in Health, as well as Dr. Sheila Davis, who is the CEO of Partners in Health, to join in this conversation today, which is focused on the role that contact tracing can play in addressing the COVID-19 pandemic and the lessons of how it's been used as a technique around the world that are now being deployed in addressing this pandemic. So welcome, Paul and Sheila. I'm hoping you'll appear on the screen any moment here. Oh, I see now. I finally see Sheila. Okay, great. And I see Paul as well. So welcome and thank you for having this conversation. I want to just say a note to the audience who's with us that this is we're going to have a quick conversation, but we're going to leave time for your questions. So please, if you have questions, use the Q&A box and queue those up, and we'll leave about 8 to 10 minutes at the end so that we can engage with some of your burning questions for these world-leading experts. So we know that Partners in Health has done some incredible work with contact tracing around the world, and we'll get to that in a moment. But in our current pandemic, in the current crisis with the novel coronavirus, Partners in Health has been working with the state of Massachusetts and really leading its contact tracing program. And so, Sheila, I want to start with you and ask you to just tell us what exactly is contact tracing and how is it being used to address COVID-19 here in Massachusetts?
Opportunity. Am I muted or can you hear me?
We hear you.
Hear you.
Okay, great, thanks. So contact tracing has been around for decades. It's not a new intervention, but it's one of the core disease control measures. So what it basically means is, finding out who potentially or who has a disease, and then tracking who they have been in contact with within certain criteria within a certain amount of time. So the point is to try to track it down and not wait until somebody gets sick before that they are brought in to be tested or for care. So for COVID-19, it's been a challenge, I think, in this country in that it wasn't started right away, probably in the most robust way it should have been, because the departments of public health, have been doing it since the beginning, but the sheer volume of cases has been challenging. So it's basically a mechanism where you find somebody who has been infected with a disease, and then you trace their contacts literally down to the people they've been with in the past period of time that they could have infected at that time. It could be that you find people who are already infected, or you find people who are just contacts, and then they're just watched and to see over time if they will become infected themselves.
And you're doing this not with an app, but with actual phone calls?
Human beings. Yeah, it's funny because, technology is extremely important, but this is a stressful thing to be told that one, you have tested positive for any type of illness or disease, or you've been exposed to it. So I think we firmly believe that human beings are a much better way to deliver this information, to be talking to people. It's talking people through, did you go to the grocery store? Were you with your babysitter? It takes a human component that has somebody who has empathy and compassion, and apps and technology can be a really supportive measure, but I don't think can ever replace that human element, which is so critical to this.
I want to get back to that in a moment, but can you tell us a little bit? I mean, Sheila, you've just done some incredible work personally with the Ebola epidemic from several years ago in West Africa. What do we know about what the important elements are for successful contact tracing based on your work with Ebola, based on your work with other diseases in the global health context?
Yeah, I think what it has shown us is that it can be done, and if it can be done in rural Sierra Leone, which does not have a very good functioning health system at this point, and spends very little on healthcare comparatively to the U.S. The kind of excuse that it can't happen here seems crazy to me, frankly. What it really takes is having care embedded in the community, and that's a piece that we're somewhat missing in the US. I think our care is very hospital focused, which we 100% need really good hospitals, but we also need care that's connected into the community. So in Sierra Leone and other places, we have community health workers who work in the communities, who are known, and it's much easier in some senses to employ an army of people who are embedded in the communities when you're already working with them on a variety of other health kind of issues. But I think Sierra Leone in particular, took this very, very seriously. And we, traced down to the last patient in Sierra Leone and in Liberia. So I think when there's the, people saying it can't happen here, it really is just a lack of imagination of how to make it happen or will to make it happen. So we can learn a lot from Haiti and cholera, Sierra Leone and Liberia for Ebola, MDR, TB in Peru. We've done this for years with many different viruses and diseases. And we just have to, I think, relook at our healthcare system. And, post-COVID or during COVID, we have to figure out how are we building back a strong public health system that is there for during pandemics and when and beyond, when we can hopefully prevent spread from things like this happening.
Thank you. I'm realizing, because I was about to ask Paul a question about the Globe, that I never introduced myself. So I'm Bina Venkataraman. I'm the Boston Globe's editorial page editor. And Paul, I want to thank you. You wrote a brilliant op-ed early on as the shutdown in the US was just starting for the Globe, where you talked about this concept of expert mercy, which I will allow you to elaborate on. But it seems to me connected to this work around contact tracing and what Sheila's describing, in that you've had to amass this cadre of people haven't really necessarily existed in our community as people who are working and know people in their communities and also working on their health. Is there a connection there between these in-person interventions that you are relying on for contact tracing and this concept of expert mercy, which, as I understand it, is the wedding of medical expertise or scientific expertise to compassion?
Yeah, I mean, thank you very much for bringing that up, Bina. As terms go, it's not a bad one. I mean, what people are looking for in the middle of outbreaks of any kind of epidemic disease, they're looking for care. They're looking for protection, for security, for reassurance. That's how we are as a species. In addition, we're saying something else, right? We're saying, oh, and by the way, you could have spread this to someone else. It's likely that you have. That's why we need to ask a bunch of questions about where you've been, who you've seen. So expert mercy in that instance includes contact tracing, because we don't have good evidence that we're going to be able to use our expertise to turn this around without something akin to contact tracing now. So, if you're clinically ill and short of breath and, you're hypoxemic, you're not getting enough oxygen in your lungs, in that instance, expert mercy is going to look a lot like a face mask with oxygen coming out of it. If you're dehydrated because you haven't had anything to eat and you've had upset stomach or nausea and vomiting, then expert mercy is going to look like IV fluids and, nursing care. So I think it varies, from place to place and time to time, but, to the extent that expertise is valuable at all, it needs to be, I was going to say cloaked in mercy, but really soaked in mercy, because this is a time when we need a lot more of those positive sentiments around, I think.
So so someone's getting a cold call, someone who has a confirmed case of COVID-19 that a healthcare facility has identified, and here in Massachusetts, that triggers a process being led by Partners in Health, as I understand it. You can correct me if I'm wrong on any of this, either of you, where then one of the trained contact tracers who you work with will call this person on the phone and try to learn about their context, understand both what's happening in terms of their own health, but who they've been in contact with. I mean, is this challenging to get people to answer their cell phones, to talk to people about who they've been in touch with? Do people feel that that's, it seems to me like some people might take that as a sort of affront to their privacy.
Right. Well, if I can just go back to what it's like to be a contact tracer when you're not obliged to do this through social distancing. First of all, this is an idea, as you know, that we really are importing from places like Haiti and Rwanda to Massachusetts. But as Sheila pointed out, this is not a new concept here. In fact, there are 350, I think, local public health offices, and they all do contact tracing. That's just in Massachusetts, by the way. And they all do contact tracing. There are probably 9 or so academic public health departments in the state, and they teach about contact tracing in addition to doing it. They train others. The issue here is that when we talk about flattening the curve, as was occurring a month or two ago, you're trying to prevent the healthcare delivery system from being overwhelmed. That includes, of course, the public health system. So in order to keep them from being overwhelmed, they need help with the contact tracing. Now, the added challenge, as you point out, Bina, is that now it's not even in person. So if you're a contact tracer, you knock on someone's door, and they almost always invite you in, by the way. And I became habituated to this in Haiti very quickly because there was so much hospitality. But when I started my first job in Massachusetts as a medical student at Harvard in the 80s, it was as a contact tracer. And I had this same experience here. People inviting you into their apartments or homes, and they're very happy to talk to you about health problems, theirs and others. The real challenge here, and I'm going to turn this over to Sheila in a minute, is how's this going to work when it's all remote, when there's not that in your living room or in your foyer kind of exchange. And, I would just say, so far, it strikes me that, again, people want that human contact, that expert mercy includes, once again, that human contact, that conversation. Maybe, Sheila, if you could, might have more to say on how it's playing out with the tens of thousands of calls that are going on now.
Sure. Yeah, I think it's been a process. I think there's, had to be an immediate campaign. And I have to say the governor has been the biggest advocate and pushing this information out in saying, pick up the phone and this is why this is important. And I think that makes a huge difference because it's being repeated in the media constantly, which is obviously huge. But I think it's taken a while. I think now there's still some people who who don't want to pick up the phone, but we leave messages and then they call back, and that's been hugely successful. And people kind of listen to what's been, somebody leaving a message saying, give us a call back. And then they do. And so that's been helpful. There's, people also, I think once they find out that somebody's there to kind of check on them, and then they continue to check on them every day through the 14 days or however long it is that they're considered potentially a case. So I think that's, shown, and there's been some really good anecdotes of the contact tracers saying that initially people were quite shy on the phone or didn't really want to chat. But then as time goes on, they really see this as a human being who's trying to help. And also a part of this process too is figuring out, does somebody need access to food? If we're saying to isolate yourselves and you can't leave and you don't have the ability to have home delivery for food, that there's also the contact tracers are seeing if they need assistance and then referring them to care coordinators who are helping figure that out. So I think people are seeing it as an asset, but it still is going to take, I think, a while for everybody to see this as a key component of stopping the spread of this. But I think it's getting better and better. And I think now it's in the media quite a few places, whereas a month ago it wasn't. So I think already there's more awareness of it. And I think we still utilize, we're an extension of, the phenomenal departments of public health. So not everybody has phones, not everybody has access. So those Department of Public Health, they have boots on the ground who the most complicated cases they find and they support in a much more comprehensive way than we can do over the phone.
So I think you're raising some fascinating points here. I think there are casual observers here in Massachusetts being such a hub of biotech and having many technology companies who wonder why we're not doing this, with the model used in South Korea or China with smartphones. And we have companies like Google and Apple who are proposing ways to do this kind of tracing in a way that would have more smartphone surveillance of our interactions engaged in the process. And I think this point you're raising about the point at which a contact tracer talks to a patient and then can figure out if they have needs around their food or just their daily survival, or even the fact that there might be a substantial number of people who don't have access to smartphones, that you're able to identify through this process. But I think what's sort of surprising is that this is a set of techniques that a practice, a sort of expertise that is in some ways feels like it's being imported from countries that have larger shares of poor people back to the US. And we're used to our health interventions, our pharmaceutical drugs going in the other direction from the wealthiest countries in the world to countries with larger shares of poor people. I'm just wondering, was it difficult to persuade the Massachusetts governor here in the world's capital of biotech to go with this more, I would say shoe leather, but I understand that it's happening on the phone, but sort of the dialing approach to doing this work?
Yeah, Dr. Jim Kim, who was one of also the founders of Partners in Health, he's the one who called up the governor and just said, I think we're missing the mark, and we're waiting for cases to come to the hospital is not the answer. So I wasn't part of that conversation, but certainly have heard that he was very open to it. And I think people want solutions, and I think was persuaded by the 35 years of PH doing this in really challenging places around the world. And I think there's a lot of things we actually get from our global colleagues and experts that we bring to the US. We just don't talk about them as much. When I was a nurse practitioner working at Mass General, I was a much better clinician because I had worked in South Africa and other places. So my physical exam skills were excellent. I couldn't rely on labs for everything or imaging for everything. So I was a much better clinician because I had worked in other places. And I think we're learning from our Rwanda colleagues who are, one of the leaders in the world in this epidemic being under control. So I hope that one silver lining of this is that we'll see that, we don't have all of the answers, and we really need to be much more open to successes that are happening around the world that are really can impact to make our healthcare better and our healthcare more comprehensive. And this is an opportunity and a window that I hope we take.
Can you tell us a little bit, maybe Paul, you can jump in on this one. We're talking mostly about Massachusetts, where as I understand it, you've recruited more than 1,000 contract tracers. How is the rest of the country, or even the rest of the world, in places that might be kind of where we are at our stage of the epidemic? How are they doing in terms of setting up contact tracing programs? Are they emulating what's happening in Massachusetts? Are they doing something different? What's the picture look like?
Well, I mean, in the places where we've been working over the years, yes, people are emulating the Massachusetts program, although they would, as you said just now, they would feel that Massachusetts is emulating their programs, right? And so Rwanda, for example, I was there in February, and they were already very well prepared for this and had already initiated contact tracing. Now, as Sheila suggested, of course, there's more of a history of epidemic disease there, so people are accustomed to the need for contact tracing. And in the case of Rwanda, over the last 2 years, there's been a major Ebola outbreak on their western flank in eastern Congo, not 100 miles from where we work in Rwanda. And so all along that border, the Ministry of Health, the public health authorities of Rwanda, were accustomed to having people doing contact tracing there. In Nigeria, for example, there was a major effort around polio eradication, which required contact tracing. So there was a great deal of familiarity because of the massive investments made there for the eradication of polio. South Korea, Taiwan, Singapore, China, places where we've seen fairly positive responses, they've all used contact tracing. And one of the things about what the governor said to me, which showed me that he was more than gung-ho about this, was he said, I am so tired, and he used much more colorful language than that. I am so tired of people giving up too early on containing this. And that's exactly the right attitude, because there's really these two matching wings of the response, the expert mercy part that has you caring for people, and the expert mercy part that has you protecting those who've already been exposed or revealing the connections that you're unaware of through contact tracing. So when this stuff comes together, that is the integration of prevention and care, you have a very, very powerful way of amplifying the messages of community health workers, with which, again, as you said, many are familiar in other countries, but we just need to have them here now.
We're going to turn to Q&A in just a moment or two. But Sheila, I want to pick up on something you said earlier, which just intrigues me to sort of ask you about the long term and our healthcare system, which is that you were pointing out that in the US, we perhaps, compared to some other countries where you've worked, including in West Africa, we have a healthcare system that emphasizes the hospital setting and that the point of care, and Paul was just talking about this as well. Do you think that there's a lesson that we can learn from this pandemic that will help us for all of the health issues we face, all of our public health issues, in terms of how to animate more contact points in the community? I'm thinking of our cluster here in Greater Boston that happened in the Chelsea neighborhood, predominantly Latino neighborhood, which it didn't get identified soon enough. And so I'm just wondering, what can we learn from what we're seeing in terms of where the model is and has been and where it needs to be to address this pandemic? What can we learn about what needs to happen for the long run in our healthcare systems?
Yeah, and we still definitely need really good hospitals in Sierra Leone and around the world. We're working really hard because we need top-rate ICUs every place we work too. So I don't want to de-emphasize the needs for hospitals, and that's one of the main things we do is try to strengthen health systems around the world. But I think here, I do think there's a lot we can learn in the fact that most care is pushed to the most expensive and the most high-tech environment. And if we look at most health issues don't require that and can happen more in community clinics, can happen in, parish nurses. There's a lot of places where if we integrated health more into our everyday lives and in our community and decentralize it, I think it's an early warning surveillance system, number one, because people are embedded in the communities. So things are when there's clusters of things happening, people notice, and it's able to be addressed quicker. And I think that takes really a re-looking at health around not just looking at health as taking care of ill people, but also how are we having the continuum of health on an ongoing wellness approach. And I also think that people would be seeking care much more frequently if it was closer to home. I think we know that we all stay within a certain miles of our home and our communities. And if we were able to look at the full spectrum and make sure people had access to the highest level of care in a hospital, but it doesn't need to, not everybody needs to seek care there. So if we are really looking at what are our departments of public health, how do we strengthen them? How do we strengthen community clinics? How do we look at where there used to be public health nurses? I'm a nurse, and there used to be public health nurses that were embedded in churches and synagogues, et cetera. And now even many schools don't even have school nurses anymore. So I think that it is an opportunity for us to relook at healthcare in this country. And it does serve as an early warning system in many ways. So it would also help in that arena, but would just help overall for, I think, health seeking behaviors and people being healthy in their communities.
Thank you. It's a fascinating prescription to think about how nurses could play a stronger role again in our community institutions. I want to make sure we get some of these wonderful questions that are coming in from the audience. And this one is great. It comes from Gina. How do you encourage the people listening to today's conversation to take action? What top 3 things should we be doing? Paul, I think you're on mute.
I mean,
There
I'll
we-
give it,
yes.
I'll give it a go as long as Sheila will get my back. I mean, the first question to ask is that one. What can I be doing? It's not straightforward. Even if you're an expert in this arena, meaning say you're like an infectious disease nurse, infectious disease doctor, someone with research and clinical skills, it still doesn't mean it's straightforward what you're going to do. I don't think either Sheila or I anticipated, responding in precisely this way. What we knew is we were going to go through this process of discernment and ask ourselves that question: how should we be helping? Because after all, the top 3 responses are going to vary from person to person. Everybody has a different set of skills. I also have been very moved, as I'm sure you have, by the creative and wonderful ways people have found to respond, whether making ersatz maps or printing ventilators or doing home deliveries for food or, sending flowers hither and yon. I mean, I just think that that's been a very uplifting part of this, and it's something we need. We need to be uplifted in that way. And I would say finding ways to be useful locally in your neighborhood could be as straightforward as checking on an elderly person or a shut-in or a family where, parents are divided between essential jobs and caring for their own elderly parents. I think that local part of the formula is important for crises like these. Sheila?
Yeah, that's great. The only thing I would add is, really adhering to the recommendations of, wearing a mask, doing things that we all should be doing to try to keep each other safe. And so I think that's certainly something that I think we can all take responsibility for. And I think also still being aware of our other places in the world that, don't have the capacity for, 200 ICU beds and that type of thing. So I think also keeping our eye also on other places and being aware of that, and us really looking at how are we going to be able to help, and how do we look at help short-term and long-term. We shouldn't have to worry about so few ventilators in any of the places that we work. that should be there. So I think also, people keeping their eye on other places in the world that don't have the same health system we do is also something I think a big part of our responsibility to keep our eye on.
So we have time for just one last quick question, though I have to say this is a hard one to answer quickly, but it's a great question that I think is just worth provoking all of us. And it's from Emily Kaiser. And she asks, how are you thinking about contact tracing in the United States when the pandemic is politicized and we struggle to agree on basic facts? Is there a precedent that you've observed elsewhere that can inform our thinking on the politics of health, or is this a uniquely American challenge?
Well, if I could just start with one thing that struck me as I did a PhD. My PhD is in anthropology, and we have this fascination with that and similar questions. But this is not a visible foe, and whether you're in the United States and which is a patchwork hodgepodge kind of culture, or you're in Sierra Leone confronting Ebola. In both cases, these are invisible foes, and local cultural or cosmological beliefs will assign different value to something that's unseen. And my experience in Haiti, Rwanda, Malawi, Lesotho, the United States, is that instead of grasping for cultural competence in answering that question, it's better just to grasp for cultural humility. People around the world have their own ideas about what causes illness and what alleviates it. When we do contact tracing, we're not out to win a bunch of converts to our way of seeing this illness or any other, right? We're trying to communicate expert mercy so that they have access to the tools of the trade, which include contact training. So I think for many of us, we don't tell people what to think about the illness so much as to say, hey, here's what we know about it. And we understand people have different views, some of them highly politicized. But here's our view. This is a respiratory illness, and it's taken a lot of lives, and we just want to make sure that it doesn't take any more. And that tends to work in my experience. People know we're not there to have a political conversation about the epidemic, but to diminish its tentacles.
Well, I wish we had time to dive into this for so much longer, but I'm told we're on a strict schedule here. I want to thank you, Sheila and Paul, not just for this incredibly interesting conversation that has so many great facets, from expert mercy to cultural humility to take away, but also for your critical work right now in this pandemic. Thank you so much. And thank you to Aspen Health for All for hosting the conversation.